We can start the address and everything else.
Well, let's start. So you first have an address, okay?
Sure.
Dr. Rodrigo, should I start sharing
Not
my
yet.
screen?
Not
Not yet?
we're
Okay.
gonna make like a few comments before me and Dr.
Okay.
Who, and then you can start. Okay.
Okay.
So Dr. Who, you first. You can start.
First?
Yes.
Okay. Hello, everyone. Today I feel honored and very happy to see the platform is established for communication between Federal University of São Paulo and Tsinghua University. Can you hear me?
Yes, we can hear you.
Okay. So yesterday is Chinese Autumn Festival. It is 15th of August of Chinese calendar. You know?
Yes, we can see that. Autumn Festival, right?
Yes. So there are always full moon. They meet Autumn Festival in China. So full moon means family back together. So we always think the 16, the more 16 longer than 15. So I think today the grand round is the unit between São Paulo University and Tsinghua University. The current technology makes the far distance between us to become close and give us the opportunity to exchange clinical experience. It will be beneficial to reach our clinical experience and promote resident training. Yeah. So first, can you introduce your resident to us?
Of course. So it's a pleasure for us to join in this first grand round between Tsinghua University and Federal University of São Paulo residents in ophthalmology. So always a pleasure to meet Dr. Hu and our friends from China. We're going to have two residents presenting. Franklin is going to be the first one. He's going to present the first case. After Franklin, we're going to have a brief discussion. So the Chinese doctors can discuss about Franklin's case. I think it should be really informal. I think the best way to do this is to, you can start the presentation, ask questions during it. So it should be very informal. So it's better to learn. After that, Dr. Hua Wang is going to present another case, and we from Brazil are going to discuss this. After him, Dr. Guillermo Macedo presents another case with a brief discussion from our Chinese colleagues. And for last but not least, Dr. Yudu presents the last case, and we discuss his case from China. So I think that's the program. That's how we should proceed right from now on. And it's already time for it. We can start, right? We can start with Dr. Franklin. What do you think, Dr. Hu?
Okay.
So Franklin, if you want to share your screen,
yeah,
you can start presenting. No problem.
My desktop. Now, is it in full screen? Right. So, good evening, everyone from the Brazilian audience, and good morning for our colleagues from Tsinghua University. It is a big pleasure to be here today sharing experiences with you guys. And the first case I'll be presenting for you is of a patient that was seen in our emergency room last year. It is a 25-year-old male patient who had a penetrating ocular trauma in his left eye 2 weeks from the retina division attending. He did it while he was doing some housework, hammering. He had a past ocular history. He was submitted to the anterior chamber reconstruction hours after the trauma in our emergency room, and he had a remarkable past medical history or family history. It is important to say that in the first evaluation, he presented with a corneal total laceration of 4 millimeters, a central corneal laceration. Posterior capsule disruption was observed during the surgery, and he had CT scans showing the presence of intraocular foreign body. So in the ophthalmologic exam after the globe reconstruction, he had no alterations in his right eye exam. In his left eye, he had a visual acuity of hands motion, a 12 millimeters of mercury intraocular pressure. I'll show you the photos of biomicroscopy. No limitations of ocular motility, and he had a possible fundus exam in the left eye. So here in the anterior biomicroscopy, he showed no normal eyelids and eyelashes, diffuse hyperemia, conjunctival hyperemia with limbal injection, the central corneal laceration with the nylon sutures, central corneal opacification, and he also had a lens opacity with posterior synechia and the presence of less than 1 millimeter hypopyon, as you can see. So for the diagnostic hypothesis so far, he had a postoperative anterior chamber reconstruction, a penetrating ocular trauma with a traumatic cataract, an intraocular foreign body, and an endophthalmitis suspicion. The first thing we thought for the management was in ocular ultrasonography, because we couldn't see the posterior pole. And just before that, I'll quickly show you the head in orbit CT scans taken before the globe repair surgery. So the top-down slices, we can see some here in the left eye, some gas bubbles. And at the level of the lens, we clearly see some irregularity of the lens when we compare it to the contralateral eye. And it is pretty evident the presence of the intraocular foreign body, as you can appreciate here. And he had no orbital bone fractures or lesions. So in the ultrasonographic images, here in this 12 o'clock axial scan, we can see the posterior lens capsule irregularity confirming the disruption of it. In the study of the macular area, we see a great amount of irregularity, suggesting a great damage to the macula, and this vitreous linear hyperreflectivity that could correspond to the intraocular foreign body vitreous path, and no and scleral wall integrity was preserved. We could see that as well. Here at the transversal scans at 3 o'clock meridian, we see this in the vitreous body, a hyperreflective of a membranous aspect, hyperreflectivity, suggesting some inflammatory and hemorrhagic processes in organized form. Here, similar images at 12 o'clock meridian. And finally, at the 5 o'clock meridian, we can see this very hyperreflective interface in the vitreous cavity that corresponded to our intraocular foreign body. in lower gain levels, we can see it more clearly. We also see the posterior detachment of the vitreous, and ultrasonographic measurements were made around 1 millimeter. At the longitudinal scans, we see the presence of subretinal fluid, suggesting retinal detachment between the 12 o'clock meridian and 3 o'clock, and also the presence of the inflammatory processes, just like I said. And for cross-reference, at the 5 o'clock, we also see the presence of the intraocular foreign body with a hyper-reflective interface. So we proceeded at the indication of the pars plana vitrectomy with intravitreal antibiotics injection and vitreous sample cultures. I'll be showing you the video of the surgery. So here we start already with the vitrectomy trocars in place and the posterior synechia breaking and placement of iris hooks by the surgeon, and then the lens aspiration was made, the lensectomy. Beginning at the vitrectomy itself, we see a massive presence of this fibrotic tissue in the vitreous body. And here I'll just quickly pause just for localization. Here's the optic disc. The macular area, we see this very dense in tissue, hemorrhagic and inflammatory tissue over the macula, and here this shiny object which corresponds to the intraocular foreign body right at the 5 o'clock position, just like we saw it at the ultrasound images. Very patiently the surgeon tries to aspirate, cleaning all of this tissue around the intraocular foreign body to detach it, making sure there's no retinal attractions before pulling the foreign body. A magnetic clamp was used to grasp it. It was brought up to the anterior chamber, and the intraocular foreign body was taken out of the eye by a corneal incision. And as you can see, it is a very clearly it is a nail head. So a metallic nail head was broken. It is a round object that caused perforation. So you can imagine the amount of energy caused by the trauma. Here in more details, the nail head had a 5 millimeters diameter, as you can see. The patient was unfortunately, his visual acuity after the surgery was a light perception, as you could see the massive macular damage. Special acknowledgement for those present in the surgery, Dr. Rodrigo and Doctors Alex and Diego from the Retina Division. And also would like to thank Dr. Liliane and Dr. Norma from the ultrasound division who helped me on this case. So some take-home points of the management, especially the preoperative management. The CT, a computer tomography should be the first imaging approach in this the suspicion of intraocular foreign bodies. It is an exam with higher sensitivity rates for different types of intraocular foreign bodies, such as wood or metal or glass, and it is generally available in the emergency setting. And also remember, it might not be a good idea to perform an ultrasound with an open globe eye. And after the globe repair, the ocular ultrasound should be the most helpful exam. for those cases, providing a detailed evaluation of the intraforeign body composition and location, having not only the diagnostic, prognostic, and purpose, but also helping the surgeon in the surgical planning. Yeah, that was a pretty straightforward case, but it is very common in our service, especially at the emergency room setting. So I'll open for discussion to be sharing experience, and thank you again for this opportunity.
Thank you, Franklin. Dr. Hu, can you hear me?
Yes.
I'm receiving like some complaints that if people getting in the meeting using the QR codes, they don't receive any image from the meeting in the internet link, not the BizConfig link. You know, if people are just watching, they're not receiving any image from the meeting. Can you check with your techniques if everything's okay?
Okay.
Yeah.
Let me check.
Yeah. Okay. The people that are not in the meeting by BizConfig are just watching. They're not being able to watch our meeting. There's no image, only sounds and with a lot of echo. Okay.
Yeah. So some people they scan the code cannot see the image, but we can see your image and the video online.
In the app, BizConfig app, it works, but the one in the internet where people are just watching, they can't participate, they don't have any image, you know. In here is okay, for us is okay, but for other people from other services, they don't receive the image, you know.
So let me check again.
Okay, so after the presentation, I think it's time for you guys to discuss the case, to make any questions you want and tell your experience on how to solve those trauma cases with IOFBs. So the ball is with China right now.
Okay, so I have a question. How many days after injury you take the vitrectomy for this patient to remove into our foreign body?
In this patient, there was a time interval of 2 weeks between the globe reconstruction that was made hours after trauma, and then the second surgery with the removal was made 2 weeks after.
Okay, but the first surgery in emergency, this patient was treated in your hospital or in other hospital?
He was treated in the teaching hospital. In the teaching hospital, in our emergency setting, we don't have the vitrectomy available. Okay. So that's why he had this the time window between both surgeries.
So I have a question. If this patient first time to come to your hospital in your emergency, are you going to remove into our foreign body in first surgery, or you will wait several days to remove it into our foreign body?
In our university, Dr. Hu, we have this main general hospital where we have the ophthalmology emergency room. And in this hospital, we don't have vitrectomy equipment to do vitrectomy. So what we normally do, those patients come in the weekends. We just make the first closure of the incision. We remove the patient, take him off of the emergency, close the incision, avoid infection, avoid losing any tissue from the wound. And normally that's done in the weekend or during the night when the patient arrives. And after that, we evaluate the patient. If we have to do vitrectomy, we have to take him to the ophthalmology department, which is another place. You know, normally take a few days to do that, because if there's a lot of blood clots, we normally wait for maybe 14 days to do the vitrectomy, remove the IFB and attach the retina. But we can't access the vitreous cavity in the general hospital. We don't have equipment for that. We just closure the eye and we do the second surgery normally in our university hospital. It's different from Tsinghua University, where you have everything in one place. You have the emergency and the operating room with vitrectomy, everything set. We have to do this in 2 separate hospitals.
So you always, the first surgery just close the wound. So
Yes.
you don't remove the upper foreign body in the first time surgery, yeah?
Only if it's very anterior, we can see the foreign body, but if it's in the vitreous cavity with a lot of blood and retinal detachment, we normally can't remove it. We leave it and we remove in a second surgery.
Okay. So, but maybe about a month ago, we meet a patient. This patient suffered intraocular foreign body. The first time we just closed the wound of cornea. But in second day, endophthalmitis developed.
Yeah, that's always a risk.
Even if we inject the antibiotic into the vitreous. But this is not always to develop, yeah?
Yeah, it's not common. We have a few cases like yours. It's very aggressive. Normally, that's not what happens. We close the wound and there's no infection in the subsequent.
Your voice.
That's always a risk. That's always a risk.
Your voice is bad.
Huh?
Your voice not good.
Oh, it's bad.
Okay.
Let me get here. Better now?
Okay.
Working.
Okay. So I have questions. What conditions you will decide to remove intraocular foreign body in emergency?
In what condition we remove?
Yes.
We try to remove every intraocular foreign body that we find. Of course, metallic foreign bodies, we try to remove it earlier because they're very toxic for the retina. But the general approach is to remove all of them. We normally try to remove them after a few days of the primary closure, normally 14 days, to allow the liquefaction of all the blood clots, so it's easier to remove the blood from the intraocular cavity and attach the retina at the same time if we need to do something to attach the retina. But the general approach is to remove all of them. We don't like to let any foreign body stay in the vitreous cavity. The only ones that we normally leave are the ones that they transfix the eye and they go to the orbital cavity. They're not intraocular anymore. If they go to the orbital cavity behind the eye, I think it's the general approach. If they're not leading to anything, we leave them there and we follow them. But if they're intraocular, we try to remove them, all of them, in the first 2 weeks.
Another question for this patient. Why you don't implant IOL intraocular lens combined with the tracheotomy? Do you always implant intraocular lens combined with tracheotomy for the injured eye?
If the patient has capsular support, we normally do that. We implant the IOL. Sometimes the patient doesn't have any capsular support, so we just leave the implantation for a second moment, a third moment, right? I think that was the case with this patient, right? No capsular support.
Yeah. It was left aphakic in the vitrectomy. Yeah.
Okay. Hi, Dr. Rodrigo. That's one.
Hi, how are you?
Okay, Rodrigo, I introduce the Professor Lin.
Yes.
Or maybe previously you didn't see him. It's
Yes.
my new college.
Yes. From Tianjin. Congratulations.
Okay, yes.
That's good memory. We have me to
Yeah.
several days ago, right?
Yes.
Okay, nice to meet you.
Oh.
Okay, let's do one more case rapidly, I think.
Great.
So,
how is the management in China? Is the same? You do it differently?
yes. I think most generally we are doing the same things, but based on the, can you hear me?
Yes.
Okay, fine. I think that the technique depends on the doctor. Actually, I'm new here. I'm in Tsinghua University, but for my technique, I do different from Doctor Who. So usually I just like you, that I remove the intraocular foreign body immediately as time the patient comes to us. So I do this for the past 20 years. But here I have to wait. I discussed this with Dr. Wu. And he told me that we can close the wound and then do the intravitreal antibiotics. So the question is, do you always do like this? Can you in the local hospital, in the teaching hospital, you can close the wound and then with the intravitreal antibiotics. That means we can reduce the risk of endophthalmitis later. So what do you think of the combination of intravitreal antibiotics? So
well, I think it's a good idea. Those foreign bodies, they're always very highly contaminated. So if you have like a ample expector antibiotics for the intraocular cavity, I think it's wise to put something inside the eye, maybe to try to wait a little bit further to remove the IOFB in the long term. I think if you have it available, I think it's a good idea. It's a good idea. Close the wound and also inject antibiotics. I think it's great. We try to do that most of the time because those IOFBs are really very infected. I think it's a wise thing to try to do. Since we don't have the vitrectomy probe available first time, normally that's how we handle those.
The second question is based on your experience. So what is the rate of endophthalmitis for this kind of patient?
Oh. Even though they're very infected, it's very low. We had a case, I think, a few months ago, but we receive a lot of those cases. Normally, like every week, we have one, and we always do this delayed surgery to remove the IOFB. So it's very, very, very unlikely that those IOFBs lead to endophthalmitis. Which is like something that surprises us because they're normally very infected, nails, things that like people like mechanics are working with, they're very dirty, but we have a very, very low rate of endophthalmitis. I could tell you like something around 1 every 20 cases shows some signs of endophthalmitis. It's not very common, Normally, most of them are without infection.
Okay. Can we go to the next speaker?
Yes.
Hello, Professor Rodrigo, can you hear me?
Yes, yes.
Hello,
Sure.
I'm Dr. Wang from Tsinghua Beijing Hospital. It is a
Great.
very good case for Dr. Franklin, and I have a question for this case. As you know, the inflammation after the surgery always very heavy for this kind of ocular trauma. So my question is, did you inject some corticosteroid like Orthodex for the patient routinely, or you just made the subconjunctival injections when you find some inflammation after the surgery?
Franklin, you want to answer?
My question is, what did you do to control the inflammation after the surgery? Do you inject the corticosteroid immediately after the surgery, or you just inject some medicine to the subconjunctival after the surgery?
I think particularly in this case, we injected the triamcinolone at the final of the surgery, but routinely, Professor Rodrigo, I don't know if we do it always.
Yeah, normally it's not routine. Normally we just treat those patients with topical and if needed, oral corticosteroids, but it's not very often used intraocular corticosteroids. Ozurdex, I can tell you, we never used. Sometimes, very few times, normally they can maybe inject triamcinolone if there's vitreal loss, but normally I can tell you maybe 90% of the cases, we just deal with the inflammation later with topical and oral corticosteroids, no intraocular ones.
Okay, thank you.
Okay. Now, Rodrigo, can we next speaker?
So sure, let's go.
Dr. Wang.
Hi, hello everyone.
Hello, I think there is no sound from Q1. You should open your microphone.
Okay. Can you hear me?
Yes, now we can hear you for sure.
Okay, so let me begin. Hi everyone, nice to meet you. Hi, hello everyone. Nice to meet you. I'm Dr. Wang from Tsinghua Beijing Hospital. It is very honored for me to share our case with you today. As you can see today, my title is a case of optic structure reconstruction after ocular trauma. In our case, the patient is a 28 years old male. His chief complaint is both eyes were injured by a broken bottle about 7 months ago. So this patient, he has undergone the vitrectomy and the lensectomy in his left eye after the surgery, and he was referred to our hospital for the advanced surgery. From these two pictures, you can see the general conditions of his anterior segment of his both eyes. The ocular examination for this patient is left eye visual acuity is 0.1, and it is only corrected to 0.2, even with pinhole. From this red marker, you can see a very obvious corneal scar. Combined with the iris defect as indicated by these two white arrows. The intraocular pressure is 1.7, and
I think
from ocular sonography, photography, and OCT scan.
Can you hear me? Can you hear me, Tsinghua? I think Dr. Hu microphone is open, so we're having echo. I think it's better now. Dr. Hu closed his microphone. Thank you. You can continue. We're having a lot of echo here.
What about now?
It's great. Now Dr. Hu closed his microphone. Thank you.
Dr. Hu should close the microphone.
Yes, now it's working. Yeah. Now it's working. Now we don't have any more echo. You can continue. Thank you.
Okay, so I will restart the page.
Sure. Now it's better? Yes. No echo.
This patient, his ocular examination, we can see his left eye visual acuity is 0.01.
Hello, guys. Tsinghua, can you open your microphone for us? Now we have no sound from Tsinghua. Tsinhua's microphone is not open. Great. Now.
Okay.
Now we have you. Great.
Okay, can you hear me?
Yes, now it's perfect.
So this patient, his left eye visual acuity is 0.01, and it is only can be corrected to 0.2, even with a pinhole. From this picture, you can see the red marker shows a very obvious corneal scar, and combined with the iris defect as indicated by these two white arrows. The ocular sonography, ocular fundus photography, and OCT scan is here, and we can tell the patient vitreous cavity is very clean, and the macular area structure is very clear. So based on this patient's ocular examination and his medical history, here is the diagnosis we give him. And in our case, the patient is a young male, and he has very strong will to improve his visual acuity and was referred to our hospital for advanced surgery. His left eye anterior segment was damaged severely. It is include the corneal scar, iris defect, and no lens. Even though the patient vitreous cavity and the macular area are all normal, but the visual acuity cannot be corrected to normal. So before the surgery, we have to ask ourselves why this happened. The reason we think about is the astigmatism for this patient. But from the corneal topography, we can see the astigmatism is not so much for this patient. And from the pictures, you can see the astigmatism did not affect his central area of the cornea heavily. So we the reason may be his optic axis was blocked by the corneal scar. And from the picture, you can see the scar gets through the central area of the cornea. And as you can see, the nasal side of his cornea is very clean. So our plan is to change the corneal scar position with the clean part. So before the surgery, we have designed the measurement. We try to, or we hope to change the position of the corneal scar to the nasal side. And here is the effect we hope to make it. And the next is the details about the surgery video. Before this, at the beginning of the surgery, we carefully examined the basal vitreous body and the oral serrata. And after this step, we made a corneal trepanation for this patient. And after the trepanation, we implant IOL into the anterior chamber. And then we remove the corneal graft and directly suture the lower margin of the iris during the open sky conditions. And after this, the last step, we rotate the cornea and make the scar change its position to the nasal side. And here is the video about this step. Here you can see we change the corneal scar position. And finally, we finish the corneal suture. So this is the 3 weeks after the surgery, and you can see the corneal scar has changed its position to the nasal superior side of the cornea, and the ocular fundus is much clearer than before. And the next is the result of his follow-up. From 3 months post-operative to 15 months, we gradually removed his corneal suture, and you can see the astigmatism decreased apparently, followed by the visual acuity can be corrected to 0.8. And these two groups of photos, you can see the astigmatism located at the superior side of the cornea, and the central area was not affected by this astigmatism. So here is the take-home message for you. As we all know, the corneal scar is one of the causes that can affect the patient's vision. So corneal rotation may be a possible treatment for the ocular trauma. Because during the surgery, we use autologous corneal graft. So it can avoid the rejections like the classical keratoplasty. And this kind of surgery is much cheaper. As you can see from the picture, the distribution of astigmatism has been changed. So this may help the patient to have a very good vision after the surgery, and it gives the patient a very good effect after the surgery. And here is all my details about the case report. And thank you for your listening. Thank you.
That's a great case, Tsinghua. I have a few questions for you. I think it's very ingenious. I really like it, the idea to use the same cornea in a young patient to avoid rejection. I think that was like very, very interesting. I have a few questions for you about the technique. I saw that you used one-piece IOL for fixation, right?
Yes.
With proline sutures, right?
Yes.
You did the fixation in the sclera, in the iris. Where was the fixation points of the IOL? I could not see it in the video.
In this case, you can see we fixation the IOL into the sulcus, but now normally we use the scleral fixation for the intraocular lens.
So in this one, you fixated in the sulcus using which technique? A scleral fixation? Through the sclera, using scleral flaps or something like that? No. How was the technique? Can you explain us? I could not see really the technique.
No fixation by suture.
Yes, we didn't use the scleral fixation. We just used the classical techniques to fix the intraocular lens.
You had a capsular support for the IOL, right?
No, this patient he has no capsular.
Oh, yeah. That's a question. How did you fixate the IOL? That's something we could not see in the video. Where did you pass the suture for the IOL in those cases? In this case,
I can give you the video again.
sure.
So here we, after we implant the IOL, we just suture the intraocular lens at the sulcus.
Like through the sclera, because we can't see where you're fixating the sutures, you know.
Hi, Dr. Rico. Can I explain?
Yes.
Okay. I think just like Dr. Wu said, it's a traditional technique. First, we put the chain zero probably through the. Can you see the left flag?
Yes, in the abdomen, right? Yeah.
It's a 10-0 probably.
Okay.
To the inferior part, there is another scleral flap. I think we just make it at the sulcus. Then
I see.
Yeah.
Just suture in the sulcus and that's it.
Suture and cut into part. And for this two part, we just suture it to the end of the IOL.
I see. All open sky technique, right? No transfixation of the sclera, right?
There's no capsular left.
I see.
It's
Great.
and we check my on it, I think.
I see. Great.
Who do it in open sky, I think. So it looks maybe looks different from the way we do in the closed eye technique. But technique is same, I think. Is a suture sulcus fixated IOL.
I see. When you have a normal surgery, closed eye without being open sky, you use like a foldable IOLs too?
Yeah.
To do fixation?
I think that depends on the doctor. For me, that maybe 10 years back, I used all of the IOL, football or one piece or three piece. I think it's okay. But for recently 7 years, I used intrascleral fixation without suture. Looks like Yamani, modified Yamani technique.
I see.
I think that's that's a better way to fix it in the long term.
I see. Great. Now I can understand. Thank you.
Okay, well.
Okay, next one.
Sure. Anyone want to comment? I don't know if Dr.
Other comment?
Yeah, Dr. Ivan is present. Ivan Minar, you want to comment anything? Dr. Ivan Minar is our chairman. He's on the room.
I cannot hear clearly.
Dr. Ivan Minar, he's our chairman. He's present. I don't know if he wants to comment something before we move on. Ivan, you're there? Maybe not now. So I think you can move on. Maybe no more comments. Great case, by the way. Great, very ingenious. Very, it's something that I'm going to consider in the future for sure. If I have a young patient with a corneal scar, that's really, really helpful, I think, for us. Thank you.
Rodrigo, yes, I'm here.
Oh,
I just
Ivan
had
is
a
here.
problem with
So,
the sound.
yeah.
Yeah.
Okay.
Yeah.
So, Dr. Who,
Yeah.
this is
Yeah.
Ivan Meinhardt. He's our chairman.
Yeah.
And
good evening, good morning for you. It's a pleasure to have this grand round with you guys from China. Very interesting and hard cases were discussed tonight for us and this morning for you guys. Thank you very much.
Okay, thank you.
so, shall we move on? So, next case is Guillermo Macedo. You can share your screen.
So, good evening for us in Brazil, good morning in China. Can you see my screen?
Yes, it's great.
So thank you, it's a pleasure for us to be united here. My name is Guillermo Macedo, I'm a second-year resident from Paulista School of Medicine, Federal University of São Paulo. I'm going to present a case from our Retina and Vitreous division. The head of the division is Dr. Rodrigo Branch. So we have a 49-year-old male patient, administrative assistant, born and raised in São Paulo, who attended our emergency room complaining of sudden painless blurred vision in the left eye and restriction of the left visual field for 4 days. For past medical history, he referred systemic arterial hypertension for 20 years, now presenting a good control of the blood pressure using only losartan twice a day, but he has a history of refractory hypertension. He even underwent investigation in the last year, and he was diagnosed with coarctation of the aorta and underwent an endovascular repair. He has also type 2 diabetes, non-insulin dependent, diagnosed 1 year ago, and his last glycated hemoglobin is almost 15%. His past ocular and family history are unremarkable. He presented visual acuity of 20/20 and 20/30, normal pupil reflex with no relative afferent pupillary defect. In the anterior biomicroscopy of both eyes, he presented normal eyelids and eyelashes, clear conjunctiva, clear cornea, deep anterior chamber without reaction, trophic iris and phakic. The intraocular pressure was 16 both eyes. I'll show the pictures of the fundoscopy. And in the confrontational visual field exam, he presented a nasal field defect in the right eye and a temporal field defect in the left eye, a pattern that reminds us of left homonymous hemianopsia. So in the fundoscopy of the right eye, we have a pink optic disc with short margins, cup to disc ratio of 0.1, a thin with entortal vessels, some AV Nicking crossing, also pupil widening vessels. We have these multiple whitish intraretinal lesions with ill-defined margins, which corresponds to Kuran-Wu spots, a normal macula and attached retina. In the left eye, we have also a pink optic disc with sharp margins, a temporal white, the same vascular abnormalities. We have the Kuran-Wu spots and some superficial intraretinal hemorrhages, a normal macula and attached retina. So for diagnostic hypothesis, initially, we have a left homonymous hemianopsia, which is not explained by the retinal findings. And we have a patient who really presents signs of a chronic hypertensive retinopathy, as the pupil widening vessels, the AV Nicking crossing, the tortals and attenuate vessels. But he has also signs of an acute hypertensive retinopathy, as the hemorrhages and Kuran-Wu spots that we could find in a context of an hypertensive emergency. But as the patient really emphasized that he had a good control of the blood pressure, we need to think about other possibilities to explain the retinal findings. So we thought about apertures like retinopathy as well. So when we have an homonymous hemianopsia, we must search for a retrochiasmal lesion. It could be secondary to a trauma, to a stroke, tumors, or even inflammatory lesions. This patient presented a left homonymous hemianopsia, so we expect to find a lesion in the right occipital lobe. So to continue our case, I would like to remind you the past medical history of the patient who referred correction of the aorta. And actually, this patient underwent a femoral catheterization for a stent replacement 4 days ago, the day that the symptoms started. And he presented important bleeding during the procedure. It was even necessary to perform a transfusion of 2 red blood cells concentrate. So what we do have is a patient who underwent a complicated hemodynamic procedure, who possibly evolved with an arterial embolism event or some hemodynamic instability. And now he's evolving with a bilateral retinopathy in an homonymous hemianopsia, which can be interpreted as a focal neurological deficit, so possibly a stroke. So for the management, we asked to check the vital signs, mainly the blood pressure, to rule out in hypertensive emergency. As we believe that the patient recently passed through an hemodynamic instability, we order a complete blood count, EKG, and cardiac enzymes. Also, to investigate other causes of apertures like retinopathy, we ask for a renal, pancreatic, rheumatological, and coagulation panel. To investigate the homonymous hemianopsia, we order a head CT, and we also performed a visual field exam, a fluorescein angiography, and an OCT. So the vital signs of the patient were all normal, even the blood pressure was 130/90. We also checked the medical records of the patient during the period that he stayed in the hospital to undergo the procedure. So he stayed in the hospital for 2 days, and during these 2 days, he presented a good control of the blood pressure. So we rule out in hypertensive emergency or in acute hypertensive retinopathy. The laboratory tests in EKG were also normal. Here we have the head CT of the patient. We can see here in the right occipital lobe, this extensive ischemic stroke already presenting hemorrhagic transformation. The localization corresponds to the clinic of our patient. Here we have the visual field exam, which confirms the left homonymous hemianopsia. Here the fluorescein angiography of the right eye. We can see a normal optic disc, increase of the vascular tortuosity, some hyperfluorescent dots next to the temporal superior arcade, and also next to the fovea, next to the disc presenting leakage during the exam. In the left eye, we also have a normal optic disc, the same vascular abnormalities, and some hyperfluorescent dots next to the fovea, next to the disc, and next to the temporal inferior arcade presenting leakage. The periphery of the both eyes were normal. Here, the OCT of the right eye, we have a preserved vitreous interface, preserved fovea depression, a normal architecture of the inner and outer retina. In the second frame, we can see this hyperreflective lesion in the nerve fiber layer, which corresponds to the Guillermo spot. In the left eye, we can see some thinning of the temporal retina, and also in the inferior retina, we can see some irregularity of the inner retina and loss of parallelism. So what we do have is a patient presenting apertures like retinopathy in an occipital stroke associated to a complicated invasive hemodynamic procedure. This patient is getting clinical and neurological follow-ups in being under surveillance. I bring here the follow-up of 2 months. He presents the same signs of the chronic hypertensive retinopathy, but an important improvement of the Guillermo spots. We have just one isolated right here. This patient presents also some signs of previous hypertensive choroidopathy. In the left eye, we have a mild pale optic disc, some hoids, the same signs of the chronic hypertensive retinopathy, but an important improvement of the Guillermo spots in intraretinal hemorrhages. We have here the pictures to comparison. The patient presents the same visual field defect, but he referred improvement of the quality of the vision. Thank you.
Great case, Guillermo. Dr. Who, anyone want to comment ask any questions about the case.
What's the systemic disease you diagnose? Systemic disease. Just the brain.
Yeah, normally systemic hypertension, I think, right? Only. Right, Guillermo? He's asking about the systemic diagnostic.
Yes. Let me put here again.
Usually we met the purchase disease, purchase retinopathy, always due to the trauma or I know the systemic infection. So for this case, I didn't met before. No, just a lesion in brain. Yeah. So I would say the causes for this persistent retinopathy from the hypertension or from the brain lesions.
Yeah, I think the brain lesion only led to the visual field defects, but everything that you see in the posterior pole was due to the systemic hypertension that he had with the hypertension crisis that caused all the Percher-like syndrome, you know.
So for this patient, can we make diagnosis is hypertension retinopathy?
Hypertension.
But this patient didn't present any hypertensive emergency. He had a good control of the blood pressure. We believe that the Percher's-like retinopathy is associated to the procedure itself. It was a complicated procedure, and there is some reports in the research literature who refers that there is some cases, even a stroke and also to Percher's-like retinopathy, reporting this case associated to angiographies and catheterism.
So this patient, you didn't give any special treatment, yeah? After 2 months, the hypertension is normal, then the Percher's retinopathy is there. So maybe I say this is the hypertension retinopathy. And it is not Percher's retinopathy. Maybe, I think.
Yeah.
Can I say something? Actually, I don't agree with Dr. Hu. I think it's a classical, it's a Percher-like retinopathy because we can see the Percher flags. That's a typical Percher flags in both eyes. But in my opinion, that maybe if you go back to the OCT scan, actually you can see for this patient we can diagnose maybe Percher-like retinopathy with tau. If you go back to the OCT scan, we can see the.
Guillermo is sharing his screen.
You can see the intermediate, maybe like the ischemia of the capillary, OCT.
Can you move to those? Oh, that's it.
You can see the palm sign in both eyes. So I think maybe the diagnosis should be Percher-like retinopathy with palm. As we all know that the Percher-like retinopathy is similar to the Percher retinopathy in the physiology. So I think it's same. But what do you think? Can you put the diagnosis apart? Do you agree?
Don't fight, you guys.
Excuse me, diagnosis for this patient. For me, I think maybe in the future, before this patient comes to hospital, maybe he had a temporal high blood pressure and induced retinopathy. So this retinal condition looks like hypertension retinopathy. It causes this patient no systemic disease, and as in my experience, usually systemic disease induce the person retinopathy. This is my different, suggestion.
So would you guys do anything different from observation in this case? Any of you guys would investigate anything else? Would you do any other management apart from observation like we did?
Here in Tsinghua University, maybe we could introduce some drugs. I don't know the name of the drugs to dilate the the pre-artery. So I think in the clinical observation, I think it can improve or shorten the duration of this kind of situation. You know, there is Chinese medicine, traditional Chinese medicine. I think that in some, like general hospital, they use some Chinese traditional medicine to improve this. I think
what kind of medicine would that be? Herbs? Teas?
Chinese medicine, some herbs.
Yeah, herbs. Yeah, but you don't know the name of the herbs, right? No. Are you familiar with the names of the herbs? No.
No.
No. I'm not familiar either. So just wondering.
Okay. So Rodrigo, can we next speaker?
Of course. Yes. Thank you, Guillermo. Great case.
Do you have any comment?
No. I think we can.
Okay.
Doctor, you do, right? Dr. Yudu took me to Chairman's Mao favorite hot pot restaurant when I was in Beijing. I think you do. Your microphone is not working. You should open your microphone. No sound so far.
Good evening, everyone.
Great. Now we have sound.
Am I heard now?
Yes.
Okay.
Great.
Shall I start?
Yes, for sure.
Are there echo?
No echo.
Okay.
No echo. It's perfect. You
All
can
right.
continue.
I am Yudu from Tsinghua University. It's my good honor to present this unusual case of high intraocular pressure. A 67-year-old female patient complained of vision decrease in the right eye for 3 days. Her past ocular history included cataract surgery for this eye 6 years before, and her medical history included systematic hypertension, malignant melanoma for half a year. She is currently under interferon therapy and recently found to have thrombocytopenia. Her physical examination showed vision decrease in both eyes, subconjunctival hemorrhage in the right eye, and her right anterior chamber is much shallower than the left one, with both anterior chambers show cells. Her right eye is showing an elevated intraocular pressure. Her fundus photography didn't show notable abnormalities, except that the right vasculature seemed to be more tortuous than the left eye. So, considering her unilateral elevated intraocular pressure and shallow anterior chamber, we initially diagnosed the patient as glaucoma If so, is it a primary or secondary glaucoma? To answer that question, we further examined ultrasound biomicroscopy for this patient and found suprachoroidal hemorrhage in the right eye, shown by red stars here. And we also found choroidal and ciliary body detachment in her left eye, also shown by red stars here. Am I heard? No. All right, let's just continue. Okay. The B-scan ultrasound also confirmed the suprachoroidal hemorrhage in the right eye compared to the relatively normal left eye. So let me conclude the clinical features here of this patient. She presented a sudden increase of intraocular pressure in the right eye, but relatively normal in the left eye. Shallower at chamber in the right eye, but deep in the left eye. And the ultrasound results show that, suprachoroidal hemorrhage in the right eye and choroidal and ciliary body detachment in the left eye. Since we initially diagnosed this patient as glaucoma, the first diagnosis we need to consider is acute primary angle closure glaucoma, considering her shallow anterior chamber and increased intraocular pressure. But this patient didn't show any ciliary hyperemia or dilated pupil, and this rarely happens in pseudophakic eyes. And the patient was showing a relatively evenly shallow anterior chamber rather than iris bone bay, which is more commonly seen in the PACG. So we didn't consider this diagnosis, and we presume that it might be a secondary glaucoma. So is it a malignant glaucoma considering her uniformly shallow anterior chamber and elevated intraocular pressure? Perhaps no, because this patient didn't show any sign of anterior rotation or edema of her ciliary body, and her posterior chamber existed. So there must be other reasons causing her secondary glaucoma, and we presume that the suprachoroidal hemorrhage is the reason that pushed forward her iris lens diaphragm and increased her intraocular pressure. So we diagnosed this patient as secondary glaucoma and hemorrhagic choroidal detachment in the right eye, choroidal and ciliary body detachment in the left eye, and iridocyclitis for both eyes. But there are still many questions to answer, like what caused the suprachoroidal hemorrhage of the right eye of this patient, and what caused the ciliary body and choroidal detachment of the left eye, and the iridocyclitis in both eyes. Carefully reviewing her past medical history, we confirmed that she was diagnosed malignant melanoma for half a year, and she is currently under interferon therapy and recently found to have thrombocytopenia. Reviewing literature, there are reports about interferon alpha showing side effects as in autoimmune diseases, including VKH syndrome. So we hypothesized that, is it because of the interferon alpha that caused an autoimmune reaction against the melanocytes in her choroid, which led to exudative processes that led to the choroidal detachment in both eyes. And her interferon alpha medicine can also explain the thrombocytopenia of this patient. Another thing is the spontaneous hemorrhagic choroidal detachment without ocular surgery or trauma. Although rare, this can happen sometimes with those risk factors. And this patient is having the thrombocytopenia by her interferon alpha, and she's having a systematic hypertension, and there might be fluctuation in intraocular pressure during the ciliary body and choroid detachment. And for her right eye, especially her right eye showed an arteriosclerotic vasculature compared to the left eye. So all these risk factors taken together might lead to the hemorrhagic choroidal detachment of this patient in the right eye. So we give her tropical steroids for both eyes. After a month, ultrasound results show that the suprachoroidal hemorrhage recovered, and her cerebral body and choroid detachment in the left eye also recovered. So this case is telling us that the diagnosis of a unilateral shallow anterior chamber with elevated intraocular pressure might not be a simple primary glaucoma. The application of interferon alpha for malignant melanoma might lead to thrombocytopenia, a local exudation in eyes, spontaneous hemorrhagic choroidal detachment, and eventually secondary glaucoma. So for us ophthalmologists, it is very important to take consideration of the patient's systematic diseases and medications that might affect the eyes. Thank you for listening. That's all for my presentation.
Great case. Congratulations.
Yvonne, you're there? You want to discuss?
I heard.
Yes, I'm here, Rodrigo. Can you hear me?
Yes, yes.
Yes, great case. Great case. Congratulations once more. And I agree, it's not primary, it's secondary. I agree with the discussion and the hypothesis. And probably due to the interferon, the patient had choroidal detachment, exudative choroidal detachment, that in the left eye was associated with a vessel rupture and a hemorrhagic choroidal detachment with shallow anterior chamber and hypertension. I think it's perfect, the rationale and the treatment. You have to give corticosteroids and try to control the IOP. You cannot drain this choroid detachment, this hemorrhagic choroid detachment immediately. You have to wait, as was discussed before in the first case by Rodrigo. And I agree completely. It's a secondary glaucoma to hemorrhagic choroid detachment in the right eye. Very good case.
Thank you.
So Professor Ivan, would you try to drainage the suprachoroidal hemorrhage of this kind of patient, just like you mentioned? So what time do you try to drainage the hemorrhage?
I missed some words from your talk, but I believe we have to wait 7 to 10 days, as Rodrigo explained. It's usual to do that, yeah, in the first case, and try to drain. Sometimes you even don't need to drain it. It depends on the amount of blood and the size of the clot. But I didn't get all the words of your talk. I'm sorry.
Okay, thank you.
I have one question for you guys. It was really marvelous, the resolution of the inflammation in the absorption of the blood. Let's think that even with ocular treatment, the pressure was too high, the choroidal detachment was not resolving. You still had this detachment of the ciliary body. Did you discuss it with the oncologist that's treating the melanoma, if it's possible to change the INF alpha for something else to try to, take away the drug that's causing the process? That's just like something that got to my mind. If there's no resolution to the process, it would be possible to change this drug, the INF alpha, for something else? For the treatment of melanoma, the melanoma, right?
So I think we have a lot of patients. Maybe in your country, I mean, you have reached a lot of patients like melanoma. So for this kind of picture, do you think that it's maybe a metastasis of melanoma or just a hemorrhage, secondary hemorrhage? Would you try to normally screen to introduce the metastasis of this kind of patient? Is that necessary?
Yeah, there's a lot of echo. I'm sorry, I think more than one people has the microphone open. We're getting a lot of echo here. Yeah. Okay. It's working. Are you guys there?
But your voice is not good, so I cannot hear.
Very, very low. My voice is low, right? Better now?
Now it's good.
Okay, great. So
I
great case.
just a thought inside, maybe in Western world, many patients suffered melanoma. Maybe they will receive the treatment by the medicine. So I think maybe this medicine induced spontaneous choroid detachment or spontaneous choroid hemorrhage, suprachoroid hemorrhage, and induced secondary glaucoma. So previously, we met the patient. They used the dial pill to for weight loss, induced the spontaneous choroid detachment, and suffered the secondary glaucoma. Did you feel the patient use the dial pill, induce the choroid detachment?
I'm sorry, Dr. Hu. Can you repeat the last phrase you said? The question for us?
Okay, I ask a question. Did you feel? Did you meet the patient? They use the diet pill, for weight loss.
Oh,
this diet pill induce the choroid detachment.
Yes.
In your hospital, did you meet the patient?
Yes. Normally, topiramate can lead to choroid detachment and anterior rotation of the ciliary body, leading to angle closure. We've seen a lot in the Western world. We have more obese patients than in Asia and China. In China, you guys are more slim than us, and we see a lot of those patients using those medications, and some patients, they develop that. The treatment is to stop the medication altogether, and normally the process stops like after a few days. But that's something we see a lot. You see that in China too, also? Very frequently? No.
We do not see that very frequently, but there are several cases.
Chinese are very slim. We envy the Chinese.
Not now.
Any question or comments? Other people? Now, Rodrigo, the time is up.
Yes.
Yeah. Can you give some summary for this grand round?
For sure.
Just a little, Rodrigo, yes. I'd like to invite you next year, please. in our another grand round with us. Would you like please accept our invitation for next year? It was wonderful today.
Yes.
Will it be an online conference or
Yeah. Can you repeat?
Dr. Nilva is our mentor here, and she's a professor at our university. So she's asking you again to repeat this grand round. You know, do it again next year.
Yes.
please?
We are all like this grand round.
For sure.
I think this is the good opportunity for us to exchange clinical experiences. So if you agree, we hope in the future we can repeat many times this international grand round. Okay?
For sure. For sure.
It will be a pleasure.
Okay.
And we should have one about glaucoma, angle closure glaucoma. It would be a great honor and pleasure to discuss angle closure glaucoma with you guys. You have so much experience with it.
Thank you.
Okay, thank you very much. So I'm glad to connect with Singapore University, and we have this platform for communication with our friend. So in the future, we hope this grand round will be held, and we continue communicate on this platform. We are very happy to talk with you on this platform, and current technology gave us a good opportunity to meet and to exchange our experiences. If you like, I think we can repeat monthly, okay?
Great. The only bad thing, normally after those meetings, Dr. Hu always take us to eat hot pot at Haidilao right in front of the hospital. So this time we won't be able to go to Haidilao.
Yeah. So I think now we have together online, but in the future maybe we have opportunity to have a party face to face.
For sure. Sure, to be a pleasure.
Maybe in February, March, anyone, maybe.
Okay.
Yes. Yeah. Let's plan it.
Great. Okay. Thank you very much. Thank you, everyone. Thank you.
Thank you.
University of São Paulo.
Thank you. Tsinghua University.
Thank you.
Great cases, great discussions, and we hope to meet you again.
And great surgery. Thank you.
Thank you. See you next time.
Okay.
Bye-bye.
See you. Bye-bye.
Bye-bye. Okay. Wow. 看一下，好吧，结束。